We are going to continue straight away from lesson 5A, where we have interpreted the normal partograph, to now lesson 5B, where we are going to interpret a partograph where there's prolonged labor. Now here you see the partograph in front of you, and just like in lesson 5A, I'm going to take hour slot by hour slot where there were recordings being made and interpret that using the 4 P's. And here is the maternal part of that same partograph, and we're also going to obviously interpret that as part of our So if we look at this first set of observations on the partograph, say for example the patient has been just admitted and you have just started assessing her on the partograph. This is your first set of observations that you have done here at 10 o'clock. We see that the passenger is, the fetal heart is still normal, it's 140 beats per minute before contraction and just about 135 after a contraction, so we're still happy. Again, we don't know what the position is, so we must make sure what the position is. We know and we have said that the position influenced the progress of labor. Membranes are still intact, so we are happy. Just coming back to the fetal heart, I beg your pardon, I haven't said enough, shown you that there's good variability and there are no deceleration. So it seems as if this patient is being on a CTG, because we can't determine variability without a patient on a CTG. So that's normal. Position we have talked about, membranes we've said is intact. The application is again poor, like in our previous case, because again the head is quite high above the pelvic brim. And the size of the baby, again, we don't know. If we look at the passage, we see that the patient is in the latent phase of labor. She's 2 centimeters dilated, but again we see that the head is quite high. The head is 4/5 above the pelvic brim here, and the descent is, the station is -2, so the head is quite high. We see that there's no molding. The bladder on the maternal side, we see she has passed 200 milliliters of urine. Her vital signs are normal, and the vagina and the cervix is normal. When we look at the powers, we see that there are 2 contractions in 10 minutes, less than 20 seconds, so the contractions are not strong yet. We again can't really say whether they're adequate or effective because we're still in the very beginning of labor. We need to see whether there's any progress. Patient is a grave 1 paranot, which again makes us a little bit worried about the head that's so high. Now, this is where it becomes so important that we also know what the position of the fetal head is. Because if we, for example, know that this head is in a, say, a left occipito-posterior position, then we know that the reason why the head might still be so high is because of also the position, because we know that in the occipito-posterior position, the diameter of the head is much bigger, that needs to go through the pelvis, than in the case of a anterior presentation, because the head's not in good flexion. So that makes it very important. Now, the vital signs we've said are normal. The urine is normal. She has passed 200 milliliters and there's nothing in it. So the bladder is not causing any obstruction and there's no problem in the urine. She hasn't received any medication. There's no signs of dehydration and ketoacidosis. And we're not sure about the pain. It doesn't look as if she really experiences pain. We need to determine whether she can cope with what she experienced. But the contractions are far apart and they're not strong. Again then, when we determine what care measures we should take, and remember that list that I gave you on the previous slide, we need to determine what a position should be, whether we should mobilize her, and I would say definitely an upright position and mobilization because the head is so high. We need to give her lots of health education, because it's still early in labor, on how to deal with the pain. We can teach her some non-pharmacological pain methods to deal with the pain, and we need to give her nutritious foods and fluids to keep her well hydrated and to prevent ketoacidosis from forming. Now, when we look at this set of observations, it was now done 4 hours later. The previous set of observations was done at 10 o'clock. Now, unfortunately, I cut off here, but here you can see this was done at 1400 hours, 4 hours later, because that's how often we're supposed to take observations in the progress of labor in the latent phase of labor. And now the patient is 5 centimeters dilated. And we've done exactly what we've done in the previous lesson. The patient is now in the active phase of labor. So we've transferred from the latent phase to the active phase, and where the patient is now 5 centimeters dilated, where it crosses the alert line, that's where we make our cross. So if we look at all our set of observations here, when the patient is now at 2 o'clock, we see that the fetal heart is still normal. There's still very little difference between the before and after contractions fetal heart. We see that the variability is good. There's no decelerations, and the membranes are still intact. So when we look here at the passenger, we see that the fetal heart's normal. Presentation is vertex. We still don't know about the position. Membranes are still intact. Application is still poor, and we will look at that just now, and we still don't know the size of the baby. When we look here at the passage, we see that there was now a little bit of progress. The patient progressed from 2 centimeters to 5 centimeters dilatation, and she's in the active phase of labor now. The engagement, the head is still high. There was absolutely no progress in the level of the head, because the head is now still 4/5 above the pelvic brim, I beg your pardon, and it's now -2 station. There's still no molding. The patient has passed 100 milliliters over 4 hours, which is a little bit little. We need to be worried about that and check that the patient passes more urine, because, as I've said, 100 milliliters is a little bit little, depending on whether the patient, how much she has, what fluid she has taken in, or in whatever way. So we need to check that. The powers we see here, the contractions are they now actually between 20 and 40 seconds. The frequency is 2 contractions in 10 minutes. We're still not very sure whether they're adequate or effective. It almost doesn't look so, because the patient, on the one hand, the patient has progressed in the sense that the cervix has dilated more, but it didn't help to get the head more engaged. So that's why we still have question marks here. We're not 100% sure whether these contractions are effective. We'll have to look now that the patient is in the active phase of labor, how it goes with that. We see that the vital signs are normal. The urine, there's nothing in the urine here that's abnormal. There's no ketoacidosis. The patient has obviously, even though the contractions are between 20 and 40 seconds long, the patient is, and only two contractions in 10 minutes, it seems as if the patient struggled to cope with the contractions. So they've decided to give her 100 milligram pethidine and Atarax. So what do we do now further with this patient here at this time at 2 o'clock in the afternoon? We kind of, there's a little bit progress in labor because the cervix has dilated more. We're happy that the fetal heart is normal, that the fetus is well, the mother is well. So those are at least okay. We are a little bit worried about the fetal head that's still very high, and the application that's not very good, which might affect this contractions here as well. Now when we look 2 hours later, now here you can see These people were not very good. They haven't monitored the fetal heart um, half hourly. Now, even it looks as if the patient had a CTG on, because we can determine, they determined that the variability and there's no decelerations. Even then, whether the patient, if, for example, the patient had a continuous CTG on, it's still very important to either then say here, continuous CTG, but even better, to still record the fetal heart, whether the patient is on a continuous CTG or not, because the CTG graph might still get lost because it's a loose document. So it's still very important to record the fetal heart on the Partograph half hourly. But we see that the fetal heart is normal. We see that the membranes have now ruptured and the liquor is clear. The patient has progressed normally. She's now 7 centimeters dilated. We have said that she should, the cervix should dilate 1 centimeter per hour, which it has. So there's seems to be good progress as far as the cervical dilatation is concerned, and there's even a little bit of progress regarding the head. It's now 3/5 above the pelvic brim, and the station is 0. There's still no molding. The bladder is, the patient has passed urine here at 2 o'clock, but now she hasn't passed any urine, and she has only passed 100 milliliters there. So I think it's really time for us to make sure that she does pass urine and that the bladder is not full. That should be one of our definite actions in this case. So we see that there's no progress really regarding the contractions. They are still between 20 and 40 seconds long. That's a mistake there. And there are 2 contractions in 10 minutes. So we almost can say that the contractions are not adequate, because remember the definition of adequate, it should be more than 2 contractions in 10 minutes. And here it stays at 2 contractions in 10 minutes. We're not sure whether it's effective. The cervix, yes, has progressed, the dilatation has progressed, and the fetal head has descended, engaged, go down into the pelvis a little bit more. So that's why the question mark is there. If we just basically look at the ineffectiveness of the contractions, one should be a little bit worried about these contractions. Then as far as the patient is concerned, everything seems to be normal. What we don't know here is 2 hours ago the patient has got, we gave a pethidine and atarax, so we need to determine now whether this had an effect or not. Can the patient go better with her pain? Did it help? So that's very important that we check that. We see, because there were no urine passed, no urine has been tested, so we're not 100% sure about the hydration and the ketoacidosis. But because labor is going on now, here we can see for already 6 hours, it becomes very important that we need to make sure that our patient stays hydrated and not getting ketoacidosis by giving her nutritional fluids and glucose, so that glucose drinks, so that she stays hydrated and not becoming ketoacidotic. As I've said, the pethidine and atarax we need to evaluate, but again also implement other measures. Again, the fetal head is still very high, so it might be a good time also for the mother to mobilize. We just need to see what the effect of this pethidine is, because it's 100 milligram, which is quite a high dosage, and the mother might not feel like walking around, or she might be dizzy, etc. Now, if we look 2 hours later at 1800 hours, when we look at the fetal observations, the passenger, nothing has really changed here, except that the application is getting better. The application is good now. But for the rest, the fetal heart is still normal. There's not a big difference here between the before and after contractions fetal heart. Again, they've only done it hourly instead of half hourly, so that's a little bit of a problem. But when we look at the passage, we see now that there's absolutely no progress regarding the cervical dilatation nor the engagement, the level of the fetal head. The head is still 3/5 above the pelvic brim, and the station is 0. There's no molding, but we see now here, I think, emptying this bladder is now becoming a priority, because the patient hasn't, she passed 100 milliliters urine there at 2 o'clock. Then at 4 o'clock, she hasn't passed any urines. Now she only passed 50 milliliters. And I think the 50 milliliters already tells you that the bladder is full. So this is time for her to empty her bladder. If she can't empty it spontaneously on the toilet, one needs to pass a urine here, a catheter here, to make sure that this bladder is empty, and that is not the reason why this head is not going down at all. As far as the powers are concerned, we see now that I really apologize. My smaller and bigger as signs are all wrong. In this case, there are 2 contractions where the contractions are longer than 40 seconds. So the contractions at least become a little bit longer, but we're still worried about the fact that there's still only 2 contractions in 10 minutes. So they're definitely not adequate and effective anymore, because the head is not going down, the cervix is not dilating, and the contractions are not effective. So when we look at our powers, the P for powers is a big problem. There's no progress here at the passage part, maybe because of that. Maybe. We'll have to see. There might be another factor of obstruction, like, for example, the full bladder, or it might be that the pelvis is just not big enough. As far as the maternal signs, we're still happy. They are all normal. There's the urine, the little urine that there was has been tested, and there's absolutely nothing abnormal in there. But they have decided, because this patient is now in prolonged labor, which was the right thing to do, was to put up a Ringer's lactate infusion of 1,000 milliliters. Now, if we go a little bit further to 8 o'clock, at 8 o'clock, here we see some other problems happening now. When we look at the fetal heart, 8 o'clock is about here. We see that the difference between the before and after contractions fetal heart rate becomes bigger. Now, if here we can see that the variability becomes fair, and that there are now late decelerations. Now, even if the mother didn't have, the fetal heart was not recorded with a CTG, as it's here, we can see that the difference between the before and after contractions fetal heart becomes now bigger, and this looks almost 20 beats per minute. So it's clear from just looking at this part of fetal heart recording that there's a big problem. But then we see also that there is a lack of or decreased variability, and there are late decelerations, which becomes very worrisome to us. That is an abnormal pattern of the fetal heart. They haven't put in anything here about the liquor, so we can't see what's the liquor going. Oh, sorry, yeah, it is meconium in the liquor, so that's another not so good sign. And we've seen that there's there's no progress in regarding the cervical dilatation and the engagement of the head. The cervix is still 7 centimeters dilated. The fetal head is now a little bit further in 2/5, but here we see another big problem under the passage, and that is the +1 molding. So even with this not so effective contractions, we have a molding which tells us that this poor fetal head struggles to go through this pelvis. So there becomes signs of fetal cephalic pelvic disproportion. Again, They've obviously not done anything about the urine, and again, there's only 50 milliliters that's been, the mother only passed 50 milliliters, so this bladder is definitely full. Then if we look at the contractions, there's nothing different on the contractions. There's still only 2 contractions longer than 40 seconds. So we can again with certainty say the contractions are not adequate and neither are they effective. They have, for some other reason, I think maybe not even reported this to a doctor, because the one possible thing that the doctor might have already started doing here when the patient was falling on the dilatation was falling on the active line was to start augmenting labor and try and get the contractions stronger and see if in that case it wouldn't help with the progress of labor. Now, when we look at the patient here, we see that she has IV on now of Ringer's lactate, which has been put on here. But here we also now see that there's ketones in the urine. So there's ketoacidosis developing. We see nothing more about pain. So here, I think the biggest problem here is the progress of labor is falling here far on the right side of the action line. So action should now definitely be taken in the sense of determining what's going on here. And I think the fact that our fetal condition is deteriorating, the maternal condition is deteriorating, there's no progress, there's signs of molding, which tells us that there is possible signs of fetal cephalic disproportion. So action in the sense of a cesarean section, I would say, is here the better. Why not augmenting with oxytocin now? Because the contractions are still not good. Why can't we give oxytocin now? Because we can't augment with labor, the moment obviously because of the fetal condition, and also we can't augment with labor when there are signs of CPD. And here we see signs of CPD. So that's a reason why why it's now really too late to start augmenting labor. And that brings us then to the end of this series of lessons on the assessment of the Partograph. And now you have to complete your final quiz so that you can get your certificate and that you can prove that you know how to do fill in and interpret the Partograph.